Today we're going to continue our discussion on the urinary system and start with urinary elimination problems. Dysuria refers to painful or difficult urination or burning on urination. It can be caused by a urinary tract infection, trauma, or urinary tract obstruction. And uresis is the involuntary loss or leakage of urine during sleep. It's also known as bedwetting. It's very normal in early childhood. During adulthood, it can be caused by hormone imbalances, urinary tract infections, sleep apnea, diabetes, constipation, nervous system disorders, or caffeine use. Hematuria refers to blood in the urine. It can be caused by kidney disease, urinary tract infection, or trauma. Nocturia is frequent urination at night. This can be caused by excess fluid intake, kidney disease, or prostate problems. Oliguria is a scant amount of urine, less than 500 milliliters in 24 hours. This can be caused by poor fluid intake, shock, burns, kidney disease, and heart failure. Next is anuria, which refers to no production of urine. Polyuria is an abnormally large amount of urine. This can be caused by medications, excess fluid intake, diabetes, and hormone imbalances. Urinary frequency refers to when people void at frequent intervals. It can be caused by excess fluid intake, urinary tract infections, pressure on the bladder, and some medications. Urinary incontinence is the involuntary loss or leakage of urine. It can be caused by trauma, disease, urinary tract infections, reproductive or urinary tract surgeries, fecal impaction, constipation, and not being able to get to the bathroom on time. Urinary retention is not being able to completely empty the bladder. It can be caused by prostate problems, nerve damage, urinary tract infection, medication, kidney stones, constipation, or trauma. Urinary urgency is the need to void at once. This can be caused by urinary tract infection, fear of incontinence, a full bladder, or stress. A urinary tract infection is usually a bacterial infection. Causes include wiping incorrectly and contaminating the urethra with bowel movement, not emptying the bladder completely, Foley catheters. Symptoms of a UTI or urinary tract infection include complaints of pain or burning with urination, urinating frequently in small amounts, blood in the urine, lower abdominal pain, flank pain, changes in mental status, and nausea. Urinary incontinence is the involuntary loss or leakage of urine. It is not a normal part of aging, and it may be temporary or permanent. There are multiple types of urinary incontinence. The first is stress incontinence. This is when urine leaks during exercise and certain movements that cause pressure on the bladder. With stress incontinence, the urine loss is small, often called dribbling. It can occur with laughing, sneezing, coughing, and lifting. With urge incontinence, urine is lost in response to the sudden, urgent need to void. The person cannot get to the toilet in time. Mixed incontinence is a combination of stress incontinence and urge incontinence. Overflow incontinence occurs when small amounts of urine leak from a full bladder. The person feels like the bladder is not empty. The person dribbles and may have a weak urine stream. With functional incontinence, the person has bladder control but cannot get to the toilet in time. Immobility and unanswered call lights are some causes. With reflex incontinence, urine is lost at predictable intervals when a specific amount of urine is in the bladder. The person does not feel the need to void. Nervous system disorders and injuries are common causes. Finally, transient incontinence is temporary or occasional incontinence that is reversed when the cause is treated. The goals of managing urinary incontinence are to prevent urinary tract infections and restore bladder function as much as possible. Urinary incontinence can lead to skin irritation, infection, and pressure injuries. Falls are a risk from trying to get to the bathroom quickly. Good skin care and dry garments and linen are essential. Incontinence products help keep the person dry. They usually have 2 layers and a waterproof back. There's pictures on upcoming slides. Bladder training may help with incontinence. Control of urination is the goal. With bladder retraining, the person needs to resist or ignore the strong desire to urinate and urinate following a schedule rather than the urge to void. The time between voidings increases as bladder retraining progresses. Prompted voiding is when the person voids at scheduled times. The person learns to recognize when the bladder is full, recognize the need to void, ask for help, and respond when prompted to void. With scheduled voiding, voiding is scheduled at regular times to match the person's voiding habits. It's usually every 2 to 4 hours while awake. The person does not delay or resist voiding. Finally, with catheter clamping, the catheter is clamped to prevent urine flow from the bladder. Urine drains when the catheter is unclamped. This picture here is an incontinence brief. This picture here shows an incontinence undergarment with a pad. This picture here shows pull-on underwear. This is a belted incontinence undergarment. Bedpans are used for elimination when a person cannot get out of bed. Fracture pans are used by persons with casts, persons in traction, persons with limited back motion, by older persons with osteoarthritis or osteoporosis, after a spinal cord injury or surgery, and after a fracture, hip fracture, or hip replacement. Bariatric bedpans can have a weight capacity of 1,200 pounds. This is a picture of a standard bedpan. This is a picture of a fracture pan. The thin end is what is placed under the resident. And this is a bariatric bedpan. Men use urinals to void. Females can also use female urinals, which are shaped to fit against a woman's body. A commode is a chair or wheelchair with an opening for a container. So on the left-hand side of the screen is a picture of a male urinal. On the right-hand side is a female urinal. After voiding, the man closes the urinal cap. This prevents urine spills. The urinal can be hung on the bed rail, wheelchair, or walker. Female urinals can be used standing, sitting, or lying down. The device is positioned snugly under the urethra. And commodes are used for persons unable to walk to the bathroom. So this is a picture of a bedside commode, like what we have in our classroom. And this is a picture of a commode chair placed over the toilet. It elevates the toilet seat so patients don't have to sit down as far. And this is a bariatric commode. So some things to report to the nurse. If the patient complains of pain or burning on urination, frequent complaints of urgency and then unable to void, patients who are voiding small, frequent amounts, any patients who have urine with a strong or unusual odor, episodes of dribbling before getting to the toilet, and the presence of blood in the urine. Catheters are a tube used to drain or inject fluid through a body opening. Catheterization is the process of inserting a catheter. Some states allow CNAs with special training to insert and remove catheters. There are a couple different types of catheters. A straight catheter is inserted into the bladder to drain it and then is removed. An indwelling catheter, otherwise known as a Foley catheter or a Foley, is left in the bladder. Urine drains constantly into a drainage bag. A suprapubic catheter is surgically inserted into the bladder through an incision above the pubis bone. And a condom catheter is a soft sheath that slides over the penis. Condom catheters are often used for incontinent men. They are also called external catheters, Texas catheters, and urinary sheaths. Tubing connects the condom catheter to a drainage bag. Some condom catheters are self-adhering. Adhesive inside the catheter sticks to the penis. Non-adhering catheters are secured with elastic tape. Apply tape in a spiral. Only use elastic tape. Adhesive tape and other tapes do not expand. So picture A shows a female catheter in a female bladder. Picture B shows a catheter in a male bladder. And then the bottom picture shows how the catheter connects to a drainage bag. This picture shows a suprapubic catheter. Catheters are used to keep the bladder empty before, during, and after surgery, to promote comfort, to protect wounds and pressure injuries from contact with urine, for hourly urine output measurements, to collect sterile urine specimens, and to measure the amount of urine in the bladder after the person voids. That's also known as residual urine. Catheters are used in dying persons to promote comfort and prevent incontinence. Catheters do not treat the cause of incontinence. They are a last resort for incontinence. Catheter-associated UTIs, also known as CAUTIs, are UTIs that occur because a catheter was placed. Catheters increase the risk of UTI. It occurs when microbes enter the urinary tract through a catheter and cause infection. It can cause severe illness and death. The urinary system is sterile. Infection can occur if microbes enter. Some facts for catheter care. First, the drainage bag should be below the bladder and off the floor. The tubing should not have kinks. The catheter should stay connected to the drainage bag. The catheter should be secured to the person's body. And perineal and catheter care should be provided according to the care plan. This shows the catheter. It's attached to the patient's body with a leg band. The drainage bag is below the bladder but off the floor. This picture here shows some other ways that catheters can be attached to the person's body so they don't pull out. There are a couple types of urine drainage systems. A closed drainage system is used for indwelling catheters. Only urine should enter the system. A standard drainage bag usually holds at least 2,000 milliliters of urine. Leg bags attached to the thigh or calf with elastic bands or Velcro. Leg bags hold less than 1,000 milliliters of urine. Leg bags are changed to standard drainage bags when the person is in bed. Drainage systems can become disconnected. If this occurs, tell the nurse at once. Do not touch the ends of the catheter or tubing. This picture here shows someone emptying a drainage bag. To empty a drainage bag, open the clamp, direct the drain into the graduate. The drain does not touch the inside of the graduate. When you're finished emptying it, you close the clamp again. An indwelling catheter has two lumens or passageways. Sterile water is injected through one lumen, the balloon inflation port, to inflate the balloon. The water is injected with a syringe. Urine drains from the bladder through the other urine. The indwelling catheter balloon is filled with 10 mLs of water. It must be deflated to 10 mLs before removing the catheter. The balloon is what holds the catheter in place in the bladder. If you remove 7 mLs of water from the balloon, the difference is 3 mLs. You should not remove the catheter. You should only remove the catheter if you can remove 10 mLs of urine. Dysuria and urinary frequency are common after removing urinary catheters. Chronic renal failure occurs when the kidneys do not function correctly. They are unable to filter waste products and toxins from the blood. With chronic renal failure, patients are unable to regulate water balance and blood pressure. The most frequent causes of chronic renal failure are high blood pressure and diabetes. Signs and symptoms include unexplained weight gain, itching, and fatigue. End-stage renal disease, or ESRD, is when the kidneys stop functioning. The resident will require dialysis or a kidney transplant. With dialysis, the resident's blood flows through a machine that filters out waste products, toxins, and extra water. It's usually performed 3 times per week, and dialysis is required to keep the patient with end-stage renal disease alive.